So Todd, what is your feeling about offering surgery, assuming the patient is in PSA remission, so to speak? Would you do it outside of a clinical trial?
Really, like a consolidative prostatectomy in the setting of somebody who responded. I don't think there's any data to support that at this point. So,
yeah. So SWOG 1802 may give us an answer if that adds anything. Definitely for radiation, STAMPEDE trial has shown that there is improved benefit with the addition of radiation to systemic therapy. I also feel that as we intensify treatment, maybe that lifelong duration could be, it becomes more easy to modify, although we've lagged behind in gathering that data. There was a DREAM trial that was conducted that completed accrual. We're waiting for the results, but that stopped treatment after 18 to 24 months if the patients were in remission. Right. And it does find the people who are very dependent. Very quickly they relapse, and you find out, sadly enough, that they need that continuous combination therapy. Anybody considering chemotherapy in this patient?
No, I would not.
What if you don't get PSA remission? Would you consider it then?
Really, no. I mean, I just, in that setting, I don't know of any data to support it.
Right.
There were some inklings that in very high-risk localized disease that chemo may be beneficial, and it just didn't seem to pan out. So yeah, really no. And frankly, a lot of guys are resistant to undergo chemotherapy. And I'm not going to try to talk them into something that I have really no great data to support.
Yeah. And some of those prognostic features that we talked about, like that Gleason score, the low volume disease, the triple therapy trials, which we'll probably talk about more, the benefit was really seen in the high volume patients. I agree with Frank. I wouldn't offer that patient chemotherapy. There are ongoing trials to answer that question you're talking about, Ulka. Like if the PSA doesn't nadir, do we add chemo at that point? And I think U of M and the VA are both opening one of the cooperative group trials for
triple switch.
Triple switch, yes. Yeah. So that is a study where if the PSA does not nadir to less than 4, I think that's the cutoff they use, then you get randomized to adding chemotherapy versus continuing on the same combination treatment. Okay, so let's get into...
Oh, I do. Do you mind if I... So the one thing that just is having so many of these conversations with Todd is that one particular challenging space for me, both as I interface with Todd and also interface with medical oncology, is a slight variation of the case where you have maybe a single lymph node in the pelvis with modest uptake, and maybe it's called equivocal on the PET scan, where Todd's worried about offering a surgery that then might need immediate radiation and hormone therapy, but that also might not be real, right? The sensitivity and specificity of those scans are not perfect. So that's one conversation. I'm curious what Todd's comment. And then on the flip side, a case where you have maybe a very active but 0.8 millimeter that clearly doesn't meet the criteria of clinical node positive, right? And are you intensifying that with the systemic therapy alongside the radiation? So it feels like PSMA opens a lot of questions around, what to do in either one of those cases.
It does, and it's just an unbelievable data desert right now, despite the fact that it's so common. And so we're going with what we think is the right thing, which at this point, we tend to agree that patients with limited PET-only nodal disease, 1 or 2 pelvic lymph nodes that are in the field where we would normally do a lymph node dissection, if they're resectable, they're still candidates for prostatectomy with lots of counseling around the high rate of recurrence, likely need for additional salvage therapies. But you don't want to take off the table an effective treatment, in a population of patients that would have been offered that treatment had we not had this new technology that has not yet been assessed in this way. So I think that's a population where we still offer surgery. That said, a patient with multiple nodes, with disease in their retroperitoneum, boy, at this point, without better data, that we don't think surgery is beneficial. Now, we still need to ask that question. We are asking that question. Hopefully we'll find out the answer to that question. But at this point, we have effective data-driven approaches like radiation and systemic therapy.
But I feel that even if there are lymph nodes in the pelvis, isn't their primary risk of progression systemic? So, you would give them, we would offer them, I think, intensification with ADT plus an oral medication, and then look into local therapy options.
Well, yeah, about 25% of patients with pathologic node positive disease at prostatectomy, low volume, pathologic node positive disease, have a durable response to that treatment, have no evidence of disease 5 years out. The catch, of course, is that patients with PET positive limited nodal disease often have not limited nodal disease at surgery. So this is what we're trying to suss out, and we just don't know yet. But no doubt, the risk for recurrence is regional.
Do we have any genomic markers that will help us choose those patients, decipher or whatever, any of those? Have those
the gene expression classifiers, Decipher, Polaris, GPS, all available at this point, unlikely to help us make those decisions today. Still, figuring that out. There's lots of studies to try to, especially Decipher is looking in this space with metastatic disease. Can it be helpful? We haven't talked yet about germline testing, right? So this is a population that are high risk, unfavorable intermediate risk patients. They should be educated around germline testing. They should undergo germline testing if they've been counseled and elect to pursue it. Patients that are, say, BRCA2 positive, these are very high-risk patients of progression, and so we may think about them differently than we might a patient without one of these mutations.
Yeah. So that brings us to a big prognostic characteristic that you mentioned, which is genomic testing. NCCN guidelines allows you to do genomic testing for anybody with high-risk prostate cancer or metastatic prostate cancer. So you could definitely, this patient would qualify based on that. Would most of you do it and use that in your prognostication?
So I think that any patient with high-risk prostate cancer or metastatic disease should have definitely germline testing done to assess their risk, but also potential therapeutic options down the line. I think all patients with advanced or metastatic disease should eventually have some genomic testing of their tumor to help guide potential future therapies as well. The timing of those things is not always clear when the best time is. As a medical oncology, seeing more advanced cases, if people have metastatic disease biopsies at the time of diagnosis, I will certainly get next generation sequencing in those patients. If they don't have, certainly at some point we will biopsy and do that testing down the line during their therapy. But I think all patients should be offered and getting germline testing from the beginning with advanced or high-risk disease.
But as of now, would that change your management?
I was going to ask Bob and Todd that because I actually don't know. Like if you someone who happened to know they were from a BRCA2 family and were BRCA2 positive, does that change your local?
It wouldn't change management up front.
Yeah. We're talking about localized disease.
Right.
Localized or
Or like that PSMA PET sensitive node or whatever. Yeah.
I guess let's keep it simple. It's the first disease we're getting.
Let's talk about the both scan
Just localized disease you're talking about?
Yeah.
Non-metastatic disease?
Yeah.
Boy, I don't know that we have fantastic data for that. We see these patients, don't we, Todd? And we sort of say, they're. Is there a possibility if you have an intact prostate cancer and that prostate is left there when radiated, and do they have some proclivity or ability to develop a second cancer in that prostate? I suppose that's possible that we talk about as at least something theoretical. But I don't know. I get the fortune of seeing a lot of patients in the same room with Todd, and most of the time, I feel like we just acknowledge the case based off of the clinical characteristics that we.
It doesn't change your management, you say?
I don't know how.
Yeah, I think it changes our prognostic assessment.
Yes, true.
It changes how we counsel. We know that if they have metastatic disease, that we have PARP inhibition out there as an option at some point at the appropriate time. But other than saying, boy, you're at extra risk of progression in the setting of a BRCA2 mutation, I don't know that it actually, at that moment in time, changes what we're going to do.